may we start our session while we'll be still nursing the issue of pulling in some of our colleagues to join along the way. Can I give this opportunity to everyone to introduce ourselves? And I'm grateful that we are also here, and I'm hoping some will also join us very soon. Or they will be able to overcome this network challenge that we are having today. But may I allow the RFM team with Zihle to introduce yourselves.
Hi everyone, my name is Eswatini. I'm with Nausea, Palliative Care Nurse at RFM Hospital.
Thank you, RFM team, for joining today. We are grateful to have you. Can I give Manzini Government Hospital?
Good afternoon, colleagues. Speaking is Tandazile Smelane from Manzini Government Hospital. I'll be joining with Eswatini.
Thank you, Manzini Hospital team. We have Rabanas here too. Rabanas, can you greet us? Rabanas, are you there? Okay. I think Rabanas will come back, team, and join us later. May I give this opportunity to Sister Mazia? Can you greet us? Can you unmute yourself and greet us and introduce others if you are joining with other people there?
Hello, how are you? I'm fine. Hello.
Yes, Mazia. We welcome you.
Hello. Hello.
Yes, Mazia.
I'm fine. I have a challenge with network, but I can hear you.
Okay. We are welcome, Mazia. We are grateful to have you. Actually, with us today, we are facing some network challenges, such that we have been able only to join with one gadget. So we hope we will finish our sessions without any interruptions. So bear with us, and we hope we will be able to pull through. Last week we were having our session, and we had a great one. We were looking at on constipation, and then we said that one of the key things that we have to do, especially here, because most of us are nurses or clinicians, is to prevent constipation as possible as we can. Please assist me whenever I'm no longer audible. Just put on chat to say you can't hear me, so I can repeat and check if I'm progressing well. So we were looking at most of the symptoms that we have in palliative care. Initially last year, we discussed the issues of the principles of symptom control, which one of the principles is to reverse the reversible and prevent the preventables. So even here today, we will be dealing with nausea and vomiting, but I would like us to give Manzini Government Hospital the opportunity to share their case. I think having the presentation after their case, as they are part of the oncology unit there, which is most related to nausea, or they have more exposure to nausea and vomiting prevention and management most of the time, as they are dealing with the chemo and stuff. So I think they can give us a certain picture of what is happening on the ground in terms of nausea and vomiting. Then after that, we will have our presentation, which will then summarize everything, I hope, that Manzini Government Hospital team will present to us now. I don't know if Tandazile, you are okay. Are you using a cell phone or a computer at the side? Tandazile, are you joining via a computer or you are using a phone?
Sorry. We tried using a computer, but yeah, we having challenges with our network as well. So I think I'll try to join using the cell phone as well. But I'm not sure how it's going to work when we're doing the presentation.
Okay, let me try use the same laptop I'm housing the sessions. So I will be able to see if we are progressing well after the presentation is done. So can I share it via here for you and then you will continue presenting, okay? Is that okay, Tandazi?
You're referring to the case presentation?
Yes. Can I share it here?
Oh, okay.
Yes.
Okay, let's see how we fare.
Okay, let me share it for you here. Can you see it?
Yeah.
Okay, you can go ahead and present it then.
Okay. Okay. Once again, good afternoon, team.
Good afternoon.
Yes.
Just give me a second, sorry. Okay. All right. Okay, yes, once again, it's Manzini Government Hospital, and probably this is our first case for 2024. And it is one complicated case. But yeah, we hope to learn as well how best can we handle this one. So we have a 37-year-old female with cervical cancer, stage 4A, and this was as per a diagnosis that was done May 2022. So she came in as a stage 4 around May 2022. She's one client who has been like pushing, and hence we still have her here. However, we started having challenges with her, particularly when it comes to issues of persistent lower back pain and vomiting, nausea and vomiting that doesn't seem to respond to most of our antiemetics. The lower back pain, she said it actually worsened after she went for radiation. We can move down. So our main concern here, for purposes of today's discussion, our main concern is actually the nausea and vomiting that doesn't seem to respond to any of our antiemetics. Yes, there is also an issue of pain which we are still struggling with, but yes, for purposes of our discussion today, we would dwell much on the nausea and vomiting. So yes, on assessment, we tried to record our history based on the recent admissions that we have had with our client. She was admitted on the 10th of January 2024. Before this one, there was another admission that was done. I think she was admitted around the 23rd of December. Then there is a recent one, 10th December, she was admitted. And yesterday, day before yesterday, she was here for consultation. Sorry, that wasn't an admission, it was consultation. But today she came back and today she was admitted. So the common history that she gives, it's the nausea and vomiting, the lower back pain and diarrhea. So even on the 22nd, she reported nausea and vomiting, anorexia, fatigue. But of note, on the 22nd of January, they said she was a bit hysteric. and she kind of requested admission, but for some reason then she was not admitted, but instead she was attended to, sent back home. Then she was given a review date, which was meant to be today, and yes, she came back today, and hence she's just been admitted. So we have a case of advanced cancer here, and there are a number of issues. But yes, we did the pain assessment because yes, she does report lower back pain. However, we are still trying to figure out, because in as much as there is that physical pain, but we are still trying to figure out if we are really dealing with if we are really dealing with physical pain or it's psychogenic pain. Because even their vomiting, we are starting to think probably it is more of a psychological issue than being of any organic cause. So yes, we did assessment to your pain, which we came to a conclusion, what's okay, there is somatic pain, because according to the CT scans, yes, there is some sort of osteoarthritis that shows, but yes, it was under inner. So yes, there is lower back pain, which rates between 7 and 9, according to what the client reported. So it's pain that comes like anytime, but she would usually say that she experiences the pain when she's seated. So she usually has difficulty sitting. When she started noticing the pain, it was when she was thriving. It actually got so severe, then she got some relief afterwards. But she had another episode again, it got so severe and it lasted for some time, but she got some relief afterwards again. So it's pain that just comes and goes. She cannot actually relate to say it worsens at night or during the day or whatsoever. But she has noted that yes, the pain is usually worse when she's seated. We termed it to be as chronic because she went for radiation somewhere around October last year. But since she came back from radiation, then she's been reporting that pain. At some point, she was even able to ambulate, despite that she has been complaining of that pain. At some point, we were thinking it probably could be delayed side effects of the radiation, but it keeps coming there. Aggravating factors, yes, it's the sitting position. Relieving factors, when she's relaxed, she says she feels a bit better. Functional impact of pain, yes, there is decreased motility, and as days goes by, it's getting worse. She's currently on medication that is prescribed for her. It's morphine and paracetamol. However, we think we have issues of adherence, because at some point she would tell you, I stopped taking the morphine because of the constipation, and also she reports nausea and vomiting post taking the morphine. So currently we are not able to manage the pain effectively, because we are having trouble with the morphine. Yet the tramadol, she reported that tramadol doesn't seem to relieve her. So yes, we have partial relief, which mostly could be due to probably other techniques, including your relaxing, your physio, because we also refer the client for physio. Then on the other side, the other type of pain, we said query psychogenic pain. We will get to that. So on physical assessment, there is lower back pain, there is abdominal distension, there is issue of not passing stools, there is nausea and vomiting, there is anorexia because of the persistent vomiting, there is like gross weight loss, which is also worrying the client as well. There is anemia. The HbA, the last time she was admitted, it was around 7.7, and we've been struggling getting bloods for her. And there's dizziness probably due to the anemia. And on her last consultation, she was even tachycardiac. probably due to the anemia as well. Then there is a lot of psychological issues that that keeps coming up. Amongst other things, there is issue of she has work-related issues. She has issues with the supervisor not understanding, and the supervisor giving her like too much workload, despite the fact that we have written a letter to inform them to say that she's still under our care and she can only take as much. So apparently the supervisor is not keen to cooperate or kind of assist her in that regard. So now she's not sure whether to continue. According to our last discussion when we saw her on her last admission, she wasn't sure whether to continue with work or to retire on medical grounds. But she's worried that if she retires now, they will have that financial burden because it will only be the husband now working. So they were still trying to figure out which one would work best for them. So we advise them they should go and figure out which one will actually work best for them. However, considering the fact that she doesn't seem to be doing well, we feel that we need to re-engage on those bases again. Then there is also issue of her being unable to perform her motherly duties and wifely roles. She mentioned that she has a 5-year-old daughter. She's autistic and she has ADHD. So, sometimes the kid would want to play with her, but then she's no longer able, and it makes her feel like less of a mother to her child. She feels she's not emotionally available for the kid. She's willing to be there for the kid, but she feels like she's dealing with a lot. And also issues of intimacy. And in as much as the husband is very much supportive, she really appreciates that, but she knows that at the end of the day, she's still supposed to be a wife to her husband. So those are some of the issues that worry her. And amongst other things, when we have this discussion, she would, from time and again, she would actually raise the issue of fearing, like she says that she's not doing well. So now she's like, her worst fear is if I don't, if the eventual, ultimately she passes on, what will happen to her husband? She's worried about what will happen to her child. So there's just a number of things that she really feels that at least not now. I know I'm not doing well, but at least if I could have time, it cannot be now. So she feels like she has that burden to keep fighting for the sake of the husband and the kid. Also, there is an issue of other kids. She had 2 kids before she got married. She had 2 kids with someone, but the father then decided to take the kids. She was okay with that because she's saying financially the father is stable and also he loves her kids. However, the issue now is each time she tries to reach out, then there was a time where she used to call the kids, but then she picked some tension between her and the kids. Sometimes they would say words that will actually hurt her so deeply. So then she said at some point she decided, okay, I do not have energy to deal with this for now. Let me just cut all communication with the kids. But then she's worried, seeing the condition now, she's worried that she hasn't had a good relationship with those kids. Unfortunately, it's like they have been turned against her. Then the other issue, it's her serostatus. She knows she's reactive. At some point, she defaulted out, but the husband knows she is reactive and has been always supportive. However, because Sisi is not doing too well now, they have her mother around to assist her around. So unfortunately, she's saying Margaret doesn't know that she's actually HIV positive and she's on ART. So we tried to encourage her that she really needs to disclose because Mage forms part of her support system. Then she said Mage would never accept an HIV, like a positive HIV status for her. We tried to encourage her that she really needs to consider because Mage would actually be assisting her without her knowing how to actually protect herself. So she has those fears. She even said that she's sometimes, because during the morning hours, she cannot take the medication while Mage is around. So she waits for Mage to leave around 12 when she goes to pick the 5-year-old daughter from school. So that is the only time she manages to take medication, meaning on weekends, she might have problems taking the medication. Unfortunately, when she takes the ARVs around 12, then find that they'll start, probably she'll start feeling the effects of the medication maybe 2 hours later. And Mage, by then, she's already back. And Mage, when she asks what happened, because you were doing fine in the morning, why the vomiting now? Why are you suddenly weak? Then she said, I would actually act surprised as well. I cannot tell her, because if I were to tell her, I think she would collapse or she would up and leave. And I don't want that at this point in moment. Social assessment, yes, she's working, her occupation, she's an HR, educational level, she did tertiary. Socioeconomic class, she's in the working class, she's married. She said she would occasionally do alcohol and smoking. The issue of smoking, I think at some point she said for the pain, she used to smoke dacha, which would give her relief at some point. But then they realized that with the dacha and morphine, the vomiting worsened. So then she decided to stop the smoking. There are no known relevant health conditions in the family. Other social related, I don't know how this one skipped. Other social related information, yes, it's the issue of the kids, which we mentioned which appeared on her psychological assessment. Then otherwise, she has a great support from the husband, it's actually from the husband, from the mom and other family members, including her in-laws. They are very, very supportive. Then when it comes to spiritual, according to her, what we picked from our discussions is that she is so much of a family person. She worries a lot about everyone else. And at the end of the day, you find that she's carrying everyone else at heart. And which actually ends up being a burden for her. So she's usually worried, if this doesn't happen my way, then this one would be hurt. If this doesn't happen the way we had anticipated, my mom would be worried. And at the end of the day, you find that she's carrying everyone else at heart, and she's just emotionally drained. Amongst her medication, there is we decided to pick like the key ones. Relevant past medication, she was once on tramadol, she's been on morphine, she's been on bisacodyl, she's been on tranexamic acid because she used to report bleeding at some point. Then she's been on amitriptyline, she's been on Prozac, which were not prescribed here, but we decided to put it here because it forms an integral part of her management. However, the Prozac and the amitriptyline, she's not taking anymore. Then for chemo, she's been on paclitaxel, carboplatin, and bevacizumab. She's currently on an antacid because of the GI irritation. She's on olanzapine. We decided to use olanzapine because it will actually, it actually has the mood stabilizing effect. It actually has an anti-emetic effect. It also probably would slightly give her a bit of sedation. Then we also give her ondansetron because ondansetron seemed to work much better than your metoclopramide because it actually acts directly on the serotonin receptors. So she usually, when she comes to hospital, she gets the ondansetron. Mostly it's given IV. Then other prescribed medication is morphine, which we said she currently is not taking. Then there's bisacordial, which she stopped as well because of the diarrhea, and she's not on active chemo currently. She's one client who has done chemo, who has done radiotherapy. And according to the recent CT scan, Dr. said, yes, there is no evidence of active cancer lung that they could pick. So apparently she was doing much better on the cancer side. However, now the challenge that we have, it's the symptoms that we have to manage and we are struggling with. Advanced care planning, DNR not done. Advanced decision to refuse treatment not yet done. Healthcare proxy not done. Mental assessment, it was done, and we came up with the conclusion, according to the recent consultation, we felt she has a MDD, it's major depressive disorder, and she also has the anxiety. Yeah, so vital signs, temperature, I was on her last consultation, temperature was 35.4, blood pressure was 128/93, the pulse was 132, probably like we had mentioned earlier, that probably due to the anemia. Respirations were fine, SpO2 was okay as well. Our client is currently on ECOG-3, which is also one thing that we really need to discuss, because on the previous admission, she had actually requested Dr. to actually cover her for a month. Then they would consider going back on the month, like beginning of February. But we need to have that discussion again, because currently, today when she was moving into the hospital, she couldn't even walk. So those are some of the discussions that we really have to have with them. Then pain score, it's around 4, which is overwhelming. Then dyspnea, she doesn't have dyspnea. As anxiety, she has severe anxiety, agitation. There's on and off, but yes, sometimes she would be very agitated. Like on her last consultation, she was very much agitated. But today she's a bit down, like really, because she's not doing fine. She's very pale. She looks like very weak. Then the depression, she has severe depression. Drowsiness, yes, and fatigue. There is moderate drowsiness and fatigue. Nausea and vomiting, which is our main concern amongst other things. Anorexia, it's severe. Constipation is severe. No trying out. Poor mobility, yes, she's I think she's highly debilitated. The blood, the HB, when we did it on her last admission, on her last admission around the 10th, it was around 7.7, but she hasn't been transfused. We only advised on diet, and she went with hematics. We're not sure what happened, but whether it was helping. But on examination today, just on physical examination, she looked like paper white. So she's back in the ward. The kidney function, we noted that the creatinine was within normal range. It's around 77. BUN as well, it was within normal range. Then this is the CT scan that was done post her chemo sessions. And according to this scan, there was no mass or neural impingement, particularly on the spinal. We had to pick the spinal one because our concern was the pain. Then further care plan, amongst other things, we felt like we need to continue with end-of-life care for the client particularly, but also we need to make the family and the husband particularly, because he's the center of her support system, to understand where we are currently. Then also on our last discussion when she was admitted, we had agreed with them, meaning the husband and the client, to say, let us try to isolate our issues and prioritize them, and also look at which ones are urgent, which need urgent attention, and which ones will be actually feasible to sort out in like as soon as possible. Also, we continue counseling on disclosure, because it will be very difficult for her to continue taking medication when someone around her doesn't even know that she's actually on this kind of medication, and it makes it difficult for Margaret to support her, not knowing what is actually going on. Because Margaret would always be worried, why is she not responding to, why is she vomiting? She was doing fine, but she wouldn't know what's actually happening. Then yes, we will continue have a counseling for the husband and other family members as deemed fit or acceptable by the client. And if possible, we'll have to advise them, because this one, it's mainly there now. Would have to advise them to arrange to meet the other kids, the ones that are not staying with her, because it's one issue that bothers her, but then trying to call them, apparently it's not working for her. So we have to actually have the family to assist to get the kids so that she gets to see them and decide what she really wants. Then we continue with MDD and anxiety management, continue with pain management. However, we're still struggling. How best can we manage the pain and the vomiting? Because we tried to rule out all possible organic causes, including your gastrointestinal irritation. She's on an antacid. She's a number of issues we have tried to address, but she's still not doing well. That is why when you look at our pain assessment somewhere out there, you'll realize that we said there is query psychogenic pain that we have to deal with. So that is why we are trying to deal with the psychological issues as much as we can. We even have a feeling that, yes, there may be issues of nausea and vomiting, which could be caused by even your antacids can cause the nausea and vomiting. Even our morphine can cause the nausea and vomiting, but it still continues even despite stopping the nausea. I mean, the morphine. There are a number of issues that could cause the nausea and vomiting. However, we feel more of our issues, they all stem from the psychological issues. That is why we are thinking we may be dealing with an issue of psychogenic pain and psychogenic or functional vomiting. So that's why we felt like probably this case we would really benefit discussing it here. We think we have tried, because the ondansetron, because what we have noticed is that when she comes and when she is admitted, you find that probably the only episode we'll experience, or we will only hear about the vomiting, but we will never actually observe any vomiting. So we have the feeling that when she's around or when she's under admission, she's able to kind of escape the reality and kind of escape the pressure that she has, like back at home. She usually does very well when she's in hospital. And for her to even say that, if you admit me, please just give me time, don't even worry about discharging me anytime. We know that she would say that, but 2 days down the line, then she would want to go back home. So those are some of the issues that we really probably need assistance with. We so much have the feeling that we are not dealing with just physical pain, but there is the possibility of us dealing with psychogenic pain and vomiting. Otherwise, thank you so much. I think we are done from our side. I'm not sure if we were still together.
Together, and thank you so much for the presentation. Tandazile. Actually, this is the classic case that you have shared with us, and it has made our presentation to be very simple for today because it's almost the whole thing that we are going to discuss today. But may I give the colleagues to share your experiences, ask any question, advise them. Manzini Government Hospital has this challenging case. This patient has been on all possible medications that they think can deal with chemical or drug-induced nausea, and they've done a physical examination to check if ever could be the progression of the cancer on the spine that comes together with pain, but the patient is not responding well. So they are requesting if we can advise them on what they can do. Their assumption now is maybe we need to strengthen on the issue of dealing with the anxiety part of, or the psychological part of it, which could be aggravating the nausea and maybe including aggravating the pain itself. I don't know what we can say. Luckily enough, we have the social worker in the house. I saw social issues there. I think she can advise you on what you can do on those issues. If there are anything she might need to add, and then we also have the nurses in the room. I also see senior nurses like Amazia there. I see other clinicians all over the country. We have our team from RFM, of which they are also exposed to such cases in most of the time. I think there's something they can add. Can I give you the opportunity, colleagues, to share? Then we'll move to our presentation. Yes, anything we want to share or ask concerning this patient who is having pain and has nausea and vomiting? Patient has been said that is no longer taking the morphine because he said it's constipation and and the nausea. But then even stopped, but the pain continues. I'm watching and looking even in my team here, who are always on the ground facing these situations. It's what they can say, and what they can advise, or what can they think we can do. Yes, you can share if it was you, what would you then do in this situation when you're faced with this patient? Or any question, maybe you wanna clarities from Manzini Hospital, they can share. If you cannot say it, you can put it on chat. I'm ready to read your comment. If you have any question. I don't know, Conan, I'm sure something. Anyone? Okay.
Hi, Sandile.
Yes, Dorothy.
How are you?
I'm fine. I'm grateful you are back after long.
No, I'm not back. I just popped in.
Yes.
Yes, thank you. Thank you so much, Tandazile, for the presentation. I think I would actually just want to make a few additions. This is a patient who is actually initially doing fairly well, and then we admitted her for the first time on the 23rd of December. She was admitted just for a day and discharged the next day. And then again, the other admission was on the 10th of January, where she was also admitted for 2 days, and then she was discharged. So during the second admission, I think that's when we actually noted, we started getting worried because this was a patient who initially wouldn't have agreed to an admission. So we have already started exploring the mental health side because we were concerned. And as Tandazile has mentioned, on admission, these symptoms that she reports, we actually never see the symptoms. So when we admit her, she's actually fine at the hospital. Hence, we actually really were drawn towards mental health issues that we needed to explore and had started exploring, I think, on the second admission. Because I think another thing that was mentioned, this is a patient who was on morphine, but stopped taking morphine and was on bisacodyl together with the morphine, and then stopped taking bisacodyl because she says it was causing her diarrhea. But now she's actually presenting with constipation and still not eager to actually go back on her medications. So that's why we are actually pulled more towards mental health issues, and that is what we are actually concentrating on now. And with this presentation today, she had actually come on Monday, on the 22nd at 10 p.m. In a hysterical state and was requesting for an admission. But after an assessment, we couldn't actually pick up any reason for admission. So that is actually another red flag to saying, why would a patient actually request to be admitted? And then had requested her to actually come back today so that she's seen by the palliative care team, where we can actually sit and have a discussion at depth about the issues. And for the work issue, she's been off work since that first admission in December, and her plan was to retire on medical grounds at the end of January, because her condition has actually deteriorated in the past 2 months, and I don't think it would be feasible for her to return back to work. So that is actually just the case in summary, where the feeling is actually more towards the mental health issues, which we need to address as soon as possible. Thank you.
Thank you, Dr. That's Dr. Dlamini from Manzini Government Hospital too. I have a comment from Zinhle RFM saying, thank you, Manzini Hospital, for the case. It's really difficult for this client. Manzini Hospital, you are right that most of the symptoms comes from the social issues. I think having a family meeting, especially the mother of the client on the issue of disclosure, will really be a good start, because the client wants to be home, but with the issues of not taking her out of this forces her to go back for admission. That's what Zinhle from RFM is suggesting. I don't know what others are saying at around 2, and then we'll move to our presentation. So 6 minutes to discuss again. To me, when I'm looking at this patient, let me share this because it has just happened to me today. Witnessing Mkonda this last week. We went to another client and we found but it's not cancer related. And then today, the patient was echo for terminal phase, with the history of stroke. So there was a lot of bed sores. So we returned and then we provided with the supplies. And then today, in my heart, I felt like, no, we need to check on him, only to be told that he has passed on. So one of the issues I discussed with them was that once a patient entered the end of life, and then there are many things that comes to them. When they can still speak, we need to discuss with them and give them the platform to share those things, especially engage their families. Because from that moment, it will be just a twinkle of an eye, they will be gone. So I think one of the issues with the patient that can help her maybe to come to terms with what is happening really with her, I think it will also to engage on agreeing on the prognosis of the disease, understanding what is it happening, and where are we going from where the patient is now in terms of the prognosis. So at the end, the patient will make an informed decision to know that, okay, now I'm not going back or I'm going forward. So because if then we have a history of this cancer and then stage 4, we know that it might be stopped in progression when we are checking there and there. But then maybe the symptoms that are coming, the cachexia, the anorexia, the vomiting, those are signs monomal that present during when we are approaching the end of life. And then the issues of emotional, psychosocial instability. the patient is like this. When we are here, the patient wants another one. When we are here, it's because there's a lot of distress that the patient is going through. So it's trying to cope with such issues. So those are sometimes the indicators that, you know, one time this patient will just be gone. So yet he has these pain issues of the unresolved issues of the children that have been neglected, the issues of undisclosure and the fear that she has towards her mother. I think addressing also those issues, as we have mentioned, the psychological part can play a major role in this issue. It is good to address them. Then in terms of the morphine, you know, some of these clients, they need just education. They have a lot of fears. You find that maybe initially when it was prescribed, she has a bad experience. So maybe explaining back again to them, they will decide why is it important to take the morphine. I think also reviewing medical or medication the patient is taking. You may find that she was also taking other drugs that she's not telling you about even at home, which might lead to polypharmacy, then it might lead to that. Another issue in terms of the vomiting, I think we also have to ascertain the issue of the environmental status at home. You know, if a patient is constantly exposed to certain smells and issues that could trigger vomiting, you will find that the fact that when we are in the hospital, we've eliminated all those smells, so you will not be experiencing the vomit. But once the patient goes back home, he goes at home where they are frying eggs in front of her, you know, they are doing all those things that might be triggering the vomiting, you know. So I think also finding all the possible causes that can be there can help us come to a point where we understand then really what could be the challenge. But my take will be on this issue, we need to also to prioritize the journey the patient is going through, looking at these pain areas that he's talking about, the worries, the fear of death, especially now that he has already said it, one of the entry point there is to open the discussion, say, you know what, I want us to discuss about your fear of death. What is it that you are scared of? And what would be the perfect death for you? And how would you want that to be addressed? So that you can share that while everyone is still there. And the issue of the mother, who would you want to support you through in this chain? I think that the patient can come into terms to know that at some point I will go and these are the issues I want to address, other than to stay in fear and all those things. And then otherwise, finding out the balance between her being worried about others other than herself. I think she's trying to display some things even concerning her life, which when you sit down with her, she would end up opening on other issues that pertains her life. I think that could be my advice. I don't know the team what they can say before maybe I rush through the presentation that we have on nausea. Yeah. I see Mike Amete is here.
Okay, good afternoon, team. Thank you, Manzini, for the case presentation. Maybe I've got one or two things to contribute. On the issue of her fears about the children and the husband, I gather that in your presentation you said the husband is very supportive. And I wonder if any of the team members has met the husband to find out his side or his understanding of the process and the diagnosis. But let me share what happened to one of the clients who were supporting, who was in a similar stage. And the situation, she was also acting very strong for her husband and her child, her son. So we had to engage the husband because he was also aware that the condition was not improving and that she was at her late stage of life. So it was a very tough confrontation in court or engagement, but we literally asked him if he would talk to his wife about the prognosis or the progression of the disease and what they've gone through. And in fact, assure her that they are aware that life might come to an end and she must not take it upon herself that she wants to live for their sake, because she was suffering and they were also suffering in the process, as they could see her in pain and she was acting strong. But to cut the long story short, he did engage the wife on this issue, and in court again, I will say, he assured her that they would still live even if she was not there. So Master Swati wamkhulula, would know she can go ahead and accept the eventuality. And I'm honest, it was a matter of 2 days. The woman slept in peace. So sometimes we have to confront the issues, but through the relatives, engage them and get their understanding and allow them to say words that they would be more comfortable with as they present their case and their love, because people try to act strong if they are suffering too much, and the carers are also suffering. So they must reach a point of understanding that, yes, this is where we are, and can we accept it? Sometimes it helps a number of people. But now it's a very tough one for a woman to see herself in this stage.
Thank you, Maria Gamet. I think she's also going back on the issue of, let's rotate around discussing the end and finding all the involved stakeholders in her life, especially the closest, which the husband and the ones he's coming close, because, you know, some will be languishing for long, yet after they can give the guarantees, Maria said, they will say, thank you. This is what I was waiting for. May God be with you. And we will all celebrate for the passing of our patient who has gone in peace, in love, and in happiness, other than dying in anguish and stress. You know, it's very painful. I saw someone was raising a hand, and then now I don't see the hand. But it's not easy to break that, because sometimes you feel like I'm going to push my patient to hopelessness, but confronting the reality, what is happening on it, because being strong while the reality is saying we need to accept what is happening, you'll find that the patient will end up loose. But I don't know how, but God give you the wisdom to know where we can start with your patient, but not hiding the truth or waiting for her for a long time until we lose her. Okay. The challenge is that once I'm putting the presentation, I will not be in a position to see your comments today. I don't know if anyone I'm leaving behind before I go to this presentation. I will not finish the presentation, is a little bit detailed, because nausea is one of the challenging and complex symptoms to deal with, because it has a lot of root causes. Then, you know, it's a free trial and error. You try this until you deal with it finally. But thank you so much, Manzini Hospital, for this case. Okay. Can I put the presentation? I can see Tandazile saying, thank you very much, team. Julie noted, who will run, we will run with all recommendations as soon as possible. And may you be empowered and while you are doing that, and enjoy the fruits that you're gonna harvest, and the patient will enjoy that. They will never forget you. Even if the patient is gone, they will remember what you did for them. That was beyond any medication. Now, can I share this presentation? I'm hoping I will just go through. It's just a repetition of Tandazile's presentation. That's why I said you must start presenting, because I knew you will bring a very wealthy case today. So, I'm trying to present this one like this. Can you see my presentation? Oh, can you see the presentation that side?
Yes, we can see it, Mr. Machado.
All right. So today we're just going to look at around nausea and vomiting. What I can say is that Nausea and vomiting is there, especially with cancer patients during their treatment and chemo, introduction of morphine and stuff. Radiation, when they are doing their curative therapies, is more common with those patients. That's why you will find them given the, is it odenastron? Yeah, Tandanzile is the good way of saying it. So normally we find them given those drugs. So it's more common with those patients. But then for all palliative care patients, it's more common when they are approaching the end. Regardless whether you have cancer, you have organ failure, it becomes more prominent and it's more distressing for the caregivers and the patient. So we'll try today look at around the emetic pathways and neurotransmitters that Tanda's even touched about today, and then recognize the different causes that can be there. And then we'll look at how we can treat and assess nausea and vomiting. In general, nausea is the unpleasant sensation of the need to vomit, and then vomiting is the expulsion of gastric content through the mouth. So these are the two different things. It's better when we found it at nauseous level, but once it reach vomiting, it becomes more complex because now you cannot give anything PO. Everything is going up. But when it's still around the nausea, you can still manage. But then once it's vomiting, then you look for other alternatives. So you need to find out and assess these symptoms now and then, especially for those patients who are at end of stage. Those ones, they have this symptom, but it's not that much prevalent or more frequently experienced compared to pain, because pain then becomes the one that even lead to patients to die in agony. But it is there also. So when we are looking at the physiology or mechanisms of nausea, so we look at the transmitters and then we have the emetic pathways. So when you look at the transmitters, we have the DA or dopamine, which is the central part of it, and then it happens, and then we have the histamines, we have the acetylcholine, we also have the serotonin, and then we have the neurokinins. So these are transmitters that normally we work around when you're dealing with nausea. And then when you talk of the emetic pathways, there's one that Tandanzile mentioned, which is the GI tract, normally where we have mucosal irritation. Most of the time with drugs and chemo and stuff, we have bowel wall invasions, where there are tumors and stuff, and then we have constipation is one of the causes standards that will lead to constipation. So when your patient is now constipated and continue vomiting, then we might need to eliminate the constipation, other than having a lot of emetic drugs, we might need to focus on eliminating the constipation. But then when there's diarrhea, then sometimes you will have constipation for a long time, and then once there's that impaction there, and then all of a sudden my patient goes to diarrhea, but the blockage is still there. And later it might even lead to expensive operations. So, yeah. And then also we have gastric stasis, especially for the bedridden ones and those who are taking drugs that lead to sedation. They end up having gastric stasis. We talked about it when talking about constipation. And then that one also may lead to nausea and vomiting. And then the neurotransmitters that are normally there are the serotonins and then the dopamine. So those are the ones that happens through the peripheral pathway. Then they irritate the vomiting center. And then we have the cerebral cortex, whereby when we talk of the cortex, we have the causes like whereby the patient will go for fear. Once your patient has fear, you'll find that the patient, when is scheduled for chemo, and then they will then begin to have nausea and vomiting because they have that anxiety and fear. And then some will have anticipated. Once you have nausea and vomiting for some time, then the patient will just know. Once he fear pots in the kitchen making some sound, and then the patient begins to vomiting because to her or him is anticipating now what will follow. And then there are issues of elevated intracranial pressure there. We talk of the pathway deals with the cortex. And then we have the chemoreceptor trigger zone, the CTZ. This one involves, Tandanzile also touched about this when he was presenting today, on this patient, that they are also, this one involves the issues of chemical irritants, and also as a result of electrolyte disturbances or imbalances, especially hypercalcemia, and then also certain drugs that might be the patient taking, they might irritate this area. And in this one, we have the dopamine neurotransmitters or receptors. We have the serotonins, and then the NK1 or the neurokinin are only related to chemo. So when your patient is on chemo, then you will find them in this. Yeah, so they will use this pathway for the vomiting. Then we have the vestibular apparatus. This one is the most common in most of us when you are going motion sickness, vertigo. So they fall under this one. So when they have emotional sickness, and then they will have this challenge, and then we call it the vestibular or the ear area. So that one will lead to, so the causes, they may differ depending on where it's coming, then you will know what you are going to use. And then all these ones, they stimulate the medulla oblongata or the vomiting center, then the patient will end up having a vomiting. Can I jump to this case? But in this case, it's almost similar to the case that we are having today. That, you know, if you have this patient who has prostate cancer with a bone metastasis, and then the patient has recently started morphine, and the patient becomes constipated with a dry mouth, and then suffers continuous nausea. And then you could suspect a certain cause of the nausea. I don't know what you can suspect there. The unfortunate part, I cannot see what people can say, but you can unmute and just say what you can suspect if this patient presents with nausea that is continuous. What can you suspect from this patient? You can just unmute and share. So we have the brain, we can suspect brain metastasis, hypercalcemia, opioid-induced nausea, constipation-induced nausea, or the ileus. What can you suspect if this patient presents to you? Prostate cancer metastasis, started morphine 3 days ago, constipated, dry mouth, but now he's presenting with continuous nausea. So there's non-stop. Now and then the patient is vomiting. What can you suspect? You can just unmute and share. I want to see you this side. Anyone who can share, what could be the cause? Anyone who can cite it and share, what can you think is the cause for this one? What can you think of will be the suspect that will lead this man to a continuous nausea? Anyone who wants to share, I can notice I can't see even on chart. What can you suspect? Mr. Jamin, what can you suspect for this one? Just 3 days ago, prostate cancer, constipation in a dry mouth. So what can we suspect? What can be the culprit here to this nausea?
Sorry, Mr. Mahlang.
Hello?
The A, B, C, D, E, are those we're supposed to be picking, or?
Yes. Choose one or two or three. Yeah. Which one can you suspect?
Okay. I'm kind of confused. It's because you are breaking, so it's sometimes we miss part of your of your now. So yes. I would have
continue.
Pardon?
Continue.
I would have suspected D, which could be constipation-induced nausea, but also because I think there is one lung that we overlook. Morphine does cause nausea and vomiting due to delayed gastric emptying, but also the constipation as well. It could it could induce nausea and vomiting.
Okay. Yes, so let's say when my patient present with continuous nausea, dry mouth, constipation, morphine 3 days, and mastitis, I can suspect opioid-induced and D, which is constipation. What can someone else say? We are just suspecting, just presented to me, dry mouth, constipated, 3 days history of taking morphine, continuous nausea, what can you suspect? Anyone wants to shoot? Okay. These are the most culprits that can be there. So I can suspect hypercalcemia and opioid because the 3 days your body is still responding. So you can suspect this and with the other symptoms that may lead to this. You remember last time when we talk about hypercalcemia, also a cause of constipation and stuff. So you can suspect that one there. These two can be your first thing to eliminate and find out if they are not there. Then you will know now you are left with constipation and mastitis to clear out. Okay. And then another area, so these are the mechanisms that normally be involved in this patient. So we have the mechanism that can be stimulated to lead to this type of nausea. So then this one will help you to know then where are you going to, how are you going to deal with this. The question then will be, then what am I going to do, right? So here, if my patient was taking morphine, or it was a hypercalcemia, then I would be suspecting dopamine receptors stimulated to lead to this nausea. Then I will look for drugs that will help me deal with this receptor. Then I will be successful in dealing with this nausea. And if it's a CTZ, then we will see that it's chemical related. And then the aldosterone, if not, I'm not mentioning bad tandazil, will help me overcome this drug or your haloperidol.
It's ondansetron.
I will never come back again. Okay, so 40% of opioid-treated patients, they experience nausea. So sometimes they go through these drugs, and then you will find that it is triggered by stimulation of the CTZ, which is most of the time is the dopamine, and then sometimes gastroparesis, peripheral, as Chanazle mentioned, that the stasis will be there. Also, it leads to dopamine receptors, and sometimes the desensitization of the liquid also will lead to this. But what worsens opioid-induced nausea is normally constipation. That one makes it more worse than becoming better. Okay, so when we are managing opioid-induced nausea and vomiting, first of all, you need to deal with the constipation, ensure it is relieved. And normally, if then it is relieved, we'll find that then nausea-induced vomiting on its own or with that emetic drugs, it tends to subside within 3 to 5 days. And once it goes further, it's a problem. But then we are expecting it not to exceed 5 days, still the patient initiated on the opioid and still having nausea and vomiting. Otherwise, it's one of the side effects of morphine, as Tanazle has mentioned, that we need to be cautious of whenever we are introducing opioids to patients. Then I have another fella who has breast cancer since 5 months, done mastectomy 5 months ago, plus adjuvant chemotherapy, and then has intense nausea after each chemo session. This is a typical patient that we usually have. And then nausea starts the day of the chemo, even before arriving at the hospital. You see this one? The nausea just the day before arriving at the hospital, the nausea starts. So in this case, which could be the culprit? What can you suspect could be the suspects for this lady? At each chemo, yes?
I don't know, but I'm thinking this could be more of anticipatory nausea because she hasn't even taken the chemo, which could have probably triggered the nausea and vomiting. So she's still going for the chemo, but then already day before she's vomiting.
Yes, Tandas, they say you can suspect that it is anticipatory psychologically, all right? It's dealing with the cortex, so it's anxiety, fear related, and anticipatory. The fact that now I have been to chemo yesterday and then now I'm coming back again, and it triggers. Someone else who can suspect another culprit in this list? Yes, Mr. Pungwa.
I concur with Chandazile that I think anticipatory nausea may be the culprit, and also chemotherapy induced nausea.
Yes, yes. Because of the chemo there, I can also suspect the nausea, right? Anyone who wants to pinpoint another culprit. Otherwise, the hypercalcemia will always be there. You will find that then I will also suspect that is my patient not in that level yet. So I will also check that one. All right. So the same thing. Then when you come in, this one also, you can see that it also involved the CTZ. And in that case, now we are going to look at the dopamine, then we are going to look at the serotonin because of, and then we'll also look at the NKs, because now we have chemo behind, you see. So then we are going to look at this, then now you have to then find a solution. Then if I put serotonin is not working, I look for a killing the NKs, then I look for dopamine options. Then I'll be rotating around this, and then also I will consider the cortex as another culprit that I'll be using. So you will find that there are many sources of the nausea, but then when we are treating it, you start with one drug, then you continue combining with the other until you find the one that will be effective to control that nausea. So even here, up to a third of patients under chemo, they suffer this type of pain, further they have anticipatory nausea and vomiting, and sometimes with late anxiety and central nausea and vomiting. And normally the treatment they will go for, to deal with anticipatory, they will go for benzodiazepines. So that's why I'm saying in Tandazile's case, it's a little bit difficult because they've tried all, but now we are left with the psychological part, how do we move our patients. So even if it's a chemo, we talk about it as I mentioned that chemo deals with the chemo receptor and the GI, which is mucosal irritation, and then the NK receptors. So we have to deal with this when we are dealing with nausea and vomiting. What I want to introduce you also to is to finding the root cause. One of the symptoms is to find what could be the possible cause of the nausea. So there are these 13 M's of emesis, or the causes of nausea and vomiting. I'll just go through, the presentation will be there, you will find it in IECO. Above the neck, we have the masses or metastasis, and the common ones also the meningeal irritation. Those are the most common ones in palliative care. But therefore, there's movement and migraine. But the two that are second, they are the most common one in palliative care. Is either the mass or metastasis and meningeal irritation. Those are the causes when it's above the neck. And then the ones that are below the neck, there are 5. But the most common ones, we have the mucosal irritation and the mechanical obstruction. That's what are below the neck, which are most common in palliative care. The others are there, but they are not much common. And then also we have the systemic causes. Then there we have the mental anxiety, of which we are not on the wrong side when we are saying for this client that we have. We have to now go check the mental anxiety or the psychological system to see how is it interfering or leading to this cause. And then we also have medications, and then we also have metabolic. We also have issues of infection that may lead to nausea. But the most common causes here are these ones: mental anxiety, medication, and metabolic. So whenever a patient has nausea, you scan through this cause and see which one is causing what. Then you link it to the MAT pathways and the neurotransmitters, then you will come up with a solution. So when you are doing your assessment, it's very important that you find out the primary diagnosis, and then you also look at comorbidities, as Tanaz said, that there are also issues that are behind here. The patient is cancer, but now we are suspecting MDD, anxiety, which might be comorbid to this problem that already the patient has. And then the experience of nausea and vomiting over time. That one I will show you, because you have to trace. It tells you then what could be the possible cause. How is the patient experiencing it? When is the nausea and how it starts? That one helps you to eliminate even the causes, because once you know the experience over time, then you will know what could be the possible cause. And then the physical examination, you know, and then setting the goals of care. This one is very important for the patients to understand that. Then we have to sit down with the patient, reverse the reversible, and then manage that we cannot reverse, so that we can manage while the patient to improve the quality of life and help the patient cope. Otherwise, the goals of care need to be set. If then we cannot finish the nausea, then how are we going to control it? Then the goals of care has to be aligned and discussed with the patient. Even end of life care goals, they need to be discussed here. And then even certain investigations will be necessary, you know. Sometimes it's not good to take a patient who's terminally take that patient to certain investigation. Actually, why do you subject a certain patient to blood examination, yet the patient is going at the end of the day? So balancing the ethics, if I'm subjecting my patient to certain investigations, will the patient benefit at the end of the day? Will I reverse then the symptom at the end of the day? So those are the things that we need to do when we are dealing with our assessment. Then if you are doing assessment over time of the nausea, these are the types of nausea. Then constant, you find that the nausea is there, it's just bouncing up and down, always there. Then we also have what we call breakthrough nausea, whereby the patient the patient has this low nausea, but all of a sudden now he has these spikes of nausea and vomiting. And then also we have intermittent, whereby there are these episodes that goes down and goes up and goes down. And then we have the examples that fit in each of these types of nauseas over time. Any nausea that is related to masses and mastitis and meningeal and irritation, you will find that the nausea is constant. And any nausea that has to do with medication, metabolic and microbes, it never subsides. It's always there. It's constant. The patient will have continuous nausea. Then you will suspect these 5 causes. That microbes, I have to eliminate. Metabolic issues, I have to eliminate. Medication causes, I have to find the irritation of the meningeal. I have to deal with mastitis. Once I'm done with this one, then I'm sure one of these will be the cause of a constant nausea. Then if my patient has breakthrough nausea, all of a sudden the nausea is spiking up, I will look for mucosal irritation, maybe post-chemo. I'm suspecting that the nausea of the patient might goes up. So I will put that way. And then mechanical obstruction. Maybe the patient, then there's been a tumor in the colon, then a certain blockage happened, or constipation happened, they didn't blocked. Then you will know now there's a fecal infection or bowel obstruction. So you will know that all of a sudden your patient experienced a spike of nausea and vomiting. You will know that the culprits that are there is mucosal irritation causes and mechanical obstruction. In mechanical obstruction, sometimes if it comes with nausea, with constipation, you will find that when your patient is constipated, all of a sudden, your patient will be vomiting. Then once the constipation is down, the patient is okay. Then they will have this intermittent vomiting. Also, patient with mental anxiety, you will find that like your patient is Tandazile. When he's in the hospital, is okay. But once the patient is at home, then there are certain issues that push the patient to come to nausea. Knowing then the experience over time, you will then be able to plot the experience and tell if it's intermittent or breakthrough, or it's just constant nausea. Then you will eventually be able to know what could be the possible cause. Then if it leads me to only mental anxiety, then now I can strictly focus on mental anxiety measures to deal with that nausea. Okay, so anorexia and constant low grade nausea, they are friends. You will find that your patient has anorexia, then they end up having nausea. Your patient have nausea, they end up having anorexia. So sometimes you need to manage both, like you say, that there are drugs that then we use in palliative care that will deal with the nausea and deal with a suspected anorexia, or that will deal with the anorexia and deal with the suspected constant low-grade nausea. So there are those drugs that we use, Tandazile shared one of them. So we have to look at those things. And then also autonomic dysfunction of delayed gastric is one of the highest cause of nausea in palliative care. Sometimes when patients, they come to hospital, they have been using corticosteroid, then there was a rapid discontinuation. If you check the file, you'll find that they've been on corticosteroid. Then if there's been rapid discontinuation, then they will present with nausea. Also, you have to identify that which medically related. So 2/3 of these causes, normally they are easily identified. You can find them. So I won't dwell that much in this presentation that what can you do in these different causes, but for masses, we know mastitis that has to do with the mass. We use corticosteroid like dexamethasone, meningeral. Sometimes they go for to reduce the mass effect, irritation, then they go for chemo, and sometimes radiation, or sometimes draining the fluids. That's what normally is done to manage this type of nauseas. But if it's mucosal, sometimes you are certain if it's not gastric acidity. Then if it's gastric acidity, we will look for anti-acid. And then in terms of proton pump inhibitors, these ones are rarely used, or they rarely give a positive effect when the nausea was related to gastric acidity. Then if it's motility, you know, we reduce the dose or stop the dose, like Mazinio government hospital has done in terms of the morphine. If we go it down, and then we try all means that are gonna increase the motility. We can go there for metoclopramide and other drugs that will increase the motility of the GI system. And then we have mental anxiety, benzodiazepines. I saw that was olanzapine. So, and then medication induced, sometimes we reduce the dose and stop, and then we look for serotonin, like, I won't mention the drug now, Tandazile, but I will mention haloperidol also there. We use it, especially in medication induced anorexia. And then we have hypercalcemia. If it's hypercalcemia, what we looked for there, do you remember that patient I said he has a dry mouth? Do you remember that, mama? That patient with a dry mouth. If the patient has a dry mouth, we say the patient is dehydrated, right? So what I'm going to do, we suspect that maybe there's hypercalcemia here. Then what I'm going to do, we rehydrate our patient, and then we ensure our patient is okay. Sometimes they go for dexamethasone and biphosphate. And then metabolic hyponatremia, we stop diuretics, and then we go for rehydration. Liver failure sometimes may lead to also nausea and vomiting. For lactulose, the one that we know. And then renal failure, they go for dialysis when it's relevant, though we know that sometimes it will not be effective. And then I will be rushing, but this is what I'm trying to say, that the key thing is find the cause of the pain, find the cause of the nausea, and then identify the type of nausea the patient is experiencing, align it with the cause. Then by doing so, you will be able to align with the true or correct management. Non-pharmacological, we do have avoid strong smells. We encourage them to eat cooler food and less aroma, eat small chunks, frequent meals, and then we also use our psychological techniques and relaxation and others that we know that we've treated in previous presentations. So under the cities that we have haloperidol, we have domepridol, metoclopramide, olanzapine, you know, I won't mention, but we have these ones that will deal with the dopamine and the histamine receptors. And then also we have if it's chemotherapy, we have Tandazile drugs and other drugs that can be used to deal with chemotherapy-induced nausea. And then there's this one that we have cortex, we have the dexamethasone or the corticosteroids that we use. There's another evidence that talks about cannabinoids that has to deal with the cannabis extracted drugs. Professor Akunda mentioned these drugs and detailed it as a psychiatrist last time in our sessions. So They also help when the nausea is induced by the cocktails, where there's anxiety and other issues. And then we have the mucosal bowel obstructions. There are many. Also, we have the haloperidol that helps us there. And then we also the lactulose. But then we have to engage the doctors there, especially to consider the best. They also have what they called acetoid. I've never seen it. It also helps in reducing the anti-secretion so that the patient can be helped with this bowel obstruction. Yes, so I will say that what we need to understand that always when there is nausea and vomiting, these are the neurotransmitters that are always there, and we need to always treat and assess for the 13 M's of MSCs. Every time there's nausea, put the 13 M's and then eliminate all those that don't fit in. Once you have get the 13 M's, it will tell you the type of nausea that the patient is going through over time. Then you are going to be able to choose the correct intervention. These are the types of drugs that are there with the examples, and the receptor involved the indication and contraindications. So I will not discuss them. Please find the presentation in our IECO presentation or IECO platform. Yeah, that's what I can present to you, colleagues. Otherwise, they did their best in terms of presenting, in terms of a case in nausea and vomiting, that it is not easy. I can see a hand is in. Oh, yes, you can talk. We can't hear you. Okay, I can see you muted, but then thank you so much, team. That's what I can say, team. There's Mr. Pumayo.
Thank you very much, Mr. Madam, for the presentation. I'm interested in knowing if there are there any other home remedies to curb nausea and vomiting. I'm cognizant of the fact that you touched base on the fact that you can curb nausea and vomiting by taking small chunks of food or using the resection techniques. What may be other home remedies that patients may take back home to curb nausea and vomiting?
Okay. Yes, yes. What do you advise your patient to take at home when they have nausea and vomiting? What do you normally say they must do? When there are no drugs, except that small frequent means is made, what can you take? What do you do when you have nausea and vomiting? Anyone wants to share? What can I advise my child to do at home?
Item.
Yes.
Yes, this one mostly we rely on information that we get from clients while sharing their experiences. Yes, obviously it will vary from their preferences. Some they usually say they use herbs like your ginger. Some do well with garlic, but for some garlic doesn't work well because of its odor. Some they try ginger biscuits. It honestly it depends on their preferences. Some use just vinegar water, some use lemon water, depending, like they use oranges, depending on their preferences and what they actually have. But one other thing that we usually encourage them to do is like thorough oral care and drink lots of fluids.
Thank you, Tandazile, for those home remedies. Okay, so those are things we do. I can see Maya Kamet. Maya Kamet, I think, was to aid in our package. I saw them with the minute they were talking. But what I can say, team, is that most of the time, what is to ascertain the cause, you know. and then you can advise them, this is what they can try. But you know, if then you know, this is the cause. For example, if then it's chemo-induced, you know exactly what is happening there, the CTZ, the dopamine, and everything is the neuroquinines, everything is stimulated, and then, but then advise them what they can take. I have seen others saying take cold ice. You know, there's a lot that people do to do that to keep nausea and vomiting. So we can encourage them to do that. But then once we have known the cause and the involved emetic pathway, and then the 3 M's, then you align them with the experience of the patient. You will be able to do that. What I can say is that there is no one way that will solve nausea. You will need multiple things to do to deal with it. So put one at a time, and then you will finally achieve your goal with your patient. I don't know if I'm leaving someone behind. Otherwise, thank you so much, colleagues. If I'm not leaving so much, thank you so much, Mazia. Thank you so much, Msuya, for joining us. Thank you so much, Rabanas. Thank you so much, Manzini Government Hospital. Tell Nombumelo I was happy to see her today, looking out and running away, Tandazile, when you saw her. I saw her, so I was happy. I have a package for her here in this platform. After a long time, we have missed her. I mean, I saw her coming and running. Thank you so much, colleagues. If then you have never been in our WhatsApp group, may I request that you join the group. I shared the link in the start. Here is the link that will take you to our WhatsApp group. Why is it not sending now? It will take you to our WhatsApp group. There's a group there. If you click this link, it will take you to our community in WhatsApp that will help us have access to information as quickly as possible. I'm looking at when our session is coming. So we have our next session on 7 February. We will be then looking at anorexia and cachexia. How do we deal with this monster in palliative care with its dilemmas that comes with it, with the emotional pain that comes with it when your patient cannot eat, but is eating but losing weight, when my patient is not eating and losing weight drastically. So how do I cope as a palliative care, or how can I help my clients to cope with that one? We'll be looking around that one in our next session. Thank you so much, Mazin Hospital, for a good case, and wish you and everyone a great week. In your emails, we'll include our feedback link. Please give us your feedback in anything you want us to improve. We'll appreciate that. We will include it in our email that we'll just send to you right after this session. Bye-bye, colleagues. Bye-bye.